Topbed Talk.
This piece is in two parts. This is part 2, presented by Professor Denny Levett and Jugdeep Dhesi, with their guest PJ Devereaux, cardiologist and clinical epidemiologist and perioperative care physician, and professor in the departments of health research methods, evidence and impact, and medicine. Director of the Division of Perioperative Care, McMaster University, Associate Deputy Director of the Population Health Research Institute, President of the Society of Perioperative Research and Care, Chloe Grimmett, National Institute of Health Research, post-doctoral research fellow and senior research fellow for the Macmillan Survivorship Research Group, the University of Southampton, Dr. Paul Wischmeyer, Professor of Anaesthesiology and Surgery at Duke Anaesthesiology.
So I'm just going to hand over to Denny.
Yeah, thank you, Jugdeep. There's lots of questions. Slido is getting very excited, and I'm going to start with the most popular question. So first of all, to you, PJ. In the United Kingdom, there's been data that's been previously published showing that out-of-hours operating leads to increased risk of mortality. And on the basis of this national audit data, we have actually tried to move operating on, for example, emergency fractured neck or femur to daytime hours because you have the best qualified team for the high-risk patients. The question was, how do you think this fits in with the hip attack data, which, as you say, there are some important differences, but there was actually no overall mortality difference between the 24-hour wait and the very fast surgery. So could we justify trying to bring surgery forward if it meant operating all night with the associated increase in mortality, because it's usually more junior staff in the middle of the night?
Yeah, so one important thing that I want to make clear about hip attack. Hip attack randomized patients to accelerated surgery or standard care who were diagnosed during working hours. So this was not patients who were being diagnosed with a hip fracture at 11 p.m. and going to the OR at 2 a.m. And the reason we did that, it was sort of following in the initial model with acute coronary syndromes and direct percutaneous coronary intervention, PCI. You first want to establish that when you have your whole team there and you have an environment which is conducive to the best outcomes, does this work? It's a separate question to know whether or not it works in the middle of the night. So all we're saying is during working hours, and centers got to define their working hours, but in general, it typically went from something like 6 or 7 in the morning till something like 3 to 8 at night. That was the typical working hours. And during that time, that's the results we see. So I'd offer a lot of caution to extrapolating those results to someone who shows up at midnight and whether or not we want to call on the team to do surgery at 3 in the morning. I think that that's a different question. So I don't think that the data of hip attack refutes in any way that, in fact, and I'm not the least bit shocked, that there may be very different outcomes when you're doing surgery at 2 in the morning compared to when you're doing it at 1.
Another quite popular question is really along the sort of similar lines, but it's about targets and perverse behaviour. We find in the UK, we've been on the receiving end of a lot of political targets, like 4 hours wait in the emergency department before you have to be admitted to a bed. And one of the frustrating things can sometimes be that you get perverse behaviour. So once you've missed the target, you then go to the bottom of the list behind all the people that are about to miss the target. And there was a question about really, is a time target, is it an absolute target, or should we just be saying we should do these patients as soon as is feasible and not delay for medical optimization?
I want to put the results into context. If you talk about all hip fractures, it is not a panacea. Doing accelerated surgery is not going to mean that everyone walks out of the hospital alive and does incredibly well. I think that there may be a subgroup where, in fact, there may be very dramatic outcomes, but that awaits the results of hip attack 2 and other trials. If you just want to use it broadly, you can have benefits from important things from delirium to urinary tract infections. And all those things make sense. And the reason I think they make sense is, well, we see, and there's some variation globally, but in general, what we see is when people show up and emerge with a hip fracture, they tend to get a Foley catheter, and it's not coming out till after surgery. And because you accelerate surgery, the catheter is coming out faster, it's not shocking that you'll drive down urinary tract infections. Because you're driving down urinary tract infections, you're having less moderate to severe pain, you're mobilizing people quicker, it's not surprising that you drive down delirium. So I think the reality is the results, they do support that likely these are results. And to the extent that one looks and says, those are important. I mean, if we did a big trial and show we decreased delirium, people, if that was the main focus, I think most people would say that's a big deal because delirium is very, it's a big issue. It's very upsetting for families and for patients. And, there's more and more data that suggests that it may not be as simple as what we think with just short-term sequelae. There may be longer-term, implications. So if one wants to say that that's worthwhile enough, and we'll see what the economic analysis shows, but if, decreasing almost a day and a half in hospital can offset that cost, then it might be worthwhile. Now, in terms of setting the timelines, I think it is a big mistake to say, look, this person passed the timeline, so forget them. They can wait a couple of days. Let's not miss the next one. I mean, I think that, obviously any of us would be very upset if that was our loved one. And I think as I said, we chose 6 hours not because we think it's magic. We wanted to have a timeline which would push people to really move to be fast, but was also credible, that we knew it was credible. The thing I can tell you is, we saw it all over the world. It's doable. And how you do it, basically how we facilitated 6 hours. The emergency room was easy to get inside because, a big focus is getting people out of the emergency room. So they knew half the patients would leave the emergency room quick. So they triaged hip fractures like they were heart attacks or strokes. They very quickly get on the diagnosis, because a lot of times we saw that people waited forever in emerge to actually get to the diagnosis because people saw it as no big deal. So we got the diagnosis quicker, but then how we accelerated the care was hospital administrators bought into, in most centers, saying, what we'll do is we'll bump into the elective OR for routine arthroplasty. So if someone was randomized to accelerate care at 9 in the morning, and the next elective case in OR 5, which was an arthroplasty room, that case bumped into it, but we wouldn't cancel any elective cases. And what we did was we purchased an extra OR slot at the end of the day to cover essentially the nurse's cost, because doctors in most countries are billing, for their governments, wherever they're billing. And the reality is, you can facilitate. So it's doable. It's like most things. When people, I'll use the analogy, when I was first doing my cardiology training, we were just starting the trials on direct PCI for acute MIs. And I remember in Canada, the trials were being led out of America. And I remember I was in Calgary at the time doing my training. I remember a lot of people sort of said, well, it's interesting we're doing this, but we're never doing this if it works because it's too expensive. We can't afford it. It's going to be a hassle. And I mean, all over the world, for the most part, now everyone does direct PCI, and certainly it happened in Canada. It's conviction. If people want to do it, you can do it. It's a bit of inconvenience, but I think for certain we should avoid having a mindset we want to hit targets, but we should not penalize someone because they missed the target and then hence they're going to wait much longer than other patients. That I would see as a big problem.
Thanks. Yeah, I would agree. And so, Paul, turning to you, there's a lot of questions about your talk. In particular, I don't know if you had the opportunity to see some of the talks earlier. We had a controversial day where we were talking about more or less, and some of the data that was reviewed in that session was the data supporting intermittent fasting as a means of pre-preparing for a subsequent stress. And so one of the most popular questions is, says, Paul, amazing talk, but how do we reconcile the pre-operative nutritional approach with the data from studies suggesting that pre-op intermittent fasting may be of benefit, and particular the studies that suggest in some instances sarcopenia is not responsive to nutritional interventions?
So those are good questions. It's interesting. I'm getting more and more, and so I'm trying to slowly familiarize myself with that literature. The last 2 or 3 lectures like this I've given around the world, doesn't seem to matter where it is, I'm starting to get these intermittent fasting questions. So it's interesting. I mean, I think as a athletic treatment for stress and for promoting leanness potentially, and for people who have metabolic inflexibility, there seems to be some data. I haven't seen any large-scale, robust data for its benefit. And the difficult part is we have hundreds, if not thousands, in fact, many thousands of patients where we've done preoperative nutrition, oral nutrition supplements, TPN, other interventions with consistent and significant benefit. So I think it's hard to argue with the fact that the data we have now is not solid. In fact, it's to the point where the NIH has said, we aren't interested in funding any more of these preoperative and immunonutrition and perioperative nutrition interventions you guys have so many thousands of patients with data saying this works. Why aren't you implementing it? This is a failure of your specialty to read the data. This isn't a failure of us to support trials doing studies of the data. And so I think we have very fundamental data that says that we need to be delivering certain fundamental higher protein supplements, which I think doesn't necessarily even speak against intermittent fasting. I think it's more the fact that the average diet of our patients in any part of the world doesn't contain enough protein, doesn't contain the micronutrients, doesn't contain a balanced diet that we evolved as humans to eat. And so I don't know that what we are advocating from the evidence, and I try not to have opinions, I try to have evidence. I don't think what we're advocating from the evidence is against intermittent fasting in any way, actually. It's more that I guess we wish people every 4 to 6 to 12 hours would take in 20, 30 grams of protein in a sufficient balanced diet and containing the micronutrients and other fundamental foods we as humans need to optimally function, especially in response to stress. And I think athletes have been teaching us that for years. If you look at how Olympic training centers train and feed people and the trials that go on there, there is a very prescribed way that we're trying to bring to surgery, much like you're trying to bring exercise at the highest level to the preoperative optimization of surgery. I think the people who perform under the greatest stress are athletes, and we need to learn from them. And the nutrition pieces and the exercise pieces, I think that we all want to bring together, mimic what this research and literature in the athletic world, which is always 20, 30 years ahead of the medical world, has shown for years. So I don't know that we're in opposition to that. It's more, I think, delivering that bolus protein throughout periods of time and just getting the necessary nutrients that most people don't take in anyway, especially protein.
Okay.
So,
one of the other issues, of course, is that we've got lots of different syndromes. We have cachexia, we have sarcopenia, we have malnutrition, and then we have obesity. And of course, every individual patient presents with a certain mix of each one of those conditions. But of course, what we see happening in the professional athletic world is individualized care. And that's going to change exactly what interventions we put in for them.
Jenny, I want to touch you. You asked about sarcopenia and lack of responsiveness to it. I think there are people that will not be very responsive because they're so anabolically inactive. I think the role for anabolic agents, first testosterone and other things, in many patients now, we have a 50,000 patient study, 43,000 patient study, showing that older men who have testosterone deficiency that take it have a 30 to 35% reduction in stroke and heart attack. And that's been shown in multiple studies now. There's a large cardiologist study saying that. So our desire to do surgery in 80s and 90 years old and then expect them to be ready for the surgery and recover when their testosterone is so deficient that they're already at a very, very high stroke and cardiac event rate, demands that we begin to look at how we're going to intervene in these anabolically deficient patients. That's only the first part, right? The second part is the exercise piece that you are such an expert of, that I think exercise and nutrition go hand in hand, and one without the other. Again, I can give all the protein I want to a patient, but if they don't do any activity, it's very likely to boast their sarcopenia issue or improve that to much degree. So it really is the hand-in-hand combination of nutrition, exercise, and potential that third arm of an anabolic signal that have to come together. And I think that's, as you said, personalizing what patients need is the future. And it's going to take both, if not all three arms.
Yeah, I would agree with that. And the individualized care, and equally exercising a patient that's malnourished is a hopeless task because they won't improve their fitness. So you can't just address one need and not the others. So, so there's a lot of questions for you, Chloe, as well. So in particular, Sonia asks, which psychological resources for stress reduction and mindfulness can we signpost patients to as a part of prehab if we don't have a psychologist as part of our team?
It's an excellent question. It's a really tricky one because there's an absolute, anyone Googles these things, there's an absolute minefield of these apps. So certainly in the UK, we tend to recommend those that are endorsed by the NHS, for example. So the NHS Choices website, will have them. It's one of the things that we've been working on in the SafeFit study, which I know has been subject to quite a lot of conversation over the last few days, is drawing together those that we know are robust and don't have a big commercial interest as well. We don't want to be signposting patients to things that suddenly they have to pay for. So looking for the free ones as well. So I couldn't tell you one off the top of my head, but NHS Choices is a good place to start. And even though teams may not have a clinical psychologist within their MDT, the clinical psychology department in the hospital, which there is usually one, will often have a suite of these things. So, for example, I've worked with a clinical psychologist at St George's, and a quick email to her, and she came through with 20 resources which they'd looked and assessed as being of value for use. So that would be my first suggestion, I think.
And referring back to the SafeFit trial, because there's a number of people who have asked, in the context of COVID and patients who are self-isolating at home, the psychological support that could be available for people we're trying to encourage home-based prehab, because obviously for those of you not from the United Kingdom, the current guidance is 2 weeks self-isolation at home before elective surgery, with advice not to leave the house apart from going into your garden. So it means we're trying to get people to do prehab in their house. And we've previously demonstrated that sometimes the compliance isn't so good when you're on your own at home, and we're trying to support this. But there's a lot of questions about what exactly that support is involving. Would you just clarify or expand on what that is in the SafeFit study?
Sure. The SafeFit study, the whole supportive intervention is designed to run for 6 months and is available for anyone at any point in the cancer pathway, so not just for pre-surgery. But the intervention itself, it pairs the participant or the person affected by cancer with a specialist exercise trainer. And most of those have come from the CAN rehab trainees, which many of you may be familiar with, but others as well. And we've given those CAN rehab instructors some additional training in psychological support and supporting nutrition. And they have a conversation with the participant up to 3 times a week for the first month, and then weekly from months 2 to 3, and then monthly thereafter. The idea being that continued support, that's a therapeutic intervention in its own right, particularly for those people who are isolated. But it also gives them the opportunity to open up the conversations about their psychological well-being, which is a direct question that many won't have been asked. How is your mental health? How are you feeling? Are you struggling with anything at the moment? And again, just that empathetic listening and sitting with those emotions can be a really therapeutic activity for patients. And much of the training for the personal trainers around the psychological support really centres around active listening, that empathetic listening, and letting go of worry for those individuals, and also normalising those feelings, particularly for those that are isolated. And then they do have access to some of the apps that we spoke about that were recommended by the St George's clinical psychologist. So that's one part of the training that the personal trainers have. And then they've also had additional training in behaviour change using the healthy conversation skills modality. And that really gives them, the personal trainers, the skills to push everything back to the patient. The idea being that they have all of the answers to how they're going to go about making those changes. They just might not know that yet. And by asking them the right questions, you unpick their priorities and you get them to really dissect their everyday lives, their priorities, and how they're going to fit things in. And by constantly asking these, we call them open discovery questions of how are you going to do that? What do you need to help with? How are we going to check back? What support do you need? That enables that individual to actually increase their confidence that they can manage these things and deal with them with that support.
Thanks, Claire. And what sort of objective tools are you using to evaluate their stress levels? Are there any screening tools? Because there's some questions around that as well.
Yeah, so there's loads out there. Again, it's a bit of a minefield. And if we look at the literature, there's a huge variation in measures used for outcomes. There's a difference also, obviously, in screening measures and measures of outcome. The one that we're using is the distress or the emotions thermometer, which you can quite easily find with a Google. And it's a fairly blunt instrument, but it's actually quite useful to just get a sense of how much people are struggling. So it's a 0 to 10 scale, and we ask how they're feeling in terms of distress, anxiety, anger, and other emotions. And if they're scoring 8 or above, then that's a real kind of indicator that they need some additional support. The GAD-7 and the PHQ-9 are also really commonly used as screening tools in the clinical psych arena. And in terms of the outcome measures, HADS, the Hospital Anxiety and Depression Scale, is one of the most commonly used. So again, there's lots out there, but in terms of using it as a screening tool to help build conversations, the distress thermometers are really useful.
Excellent. Thanks, Chloe. And then, PJ, moving back to the HIPATAC trial, there's quite a lot of questions about the anaesthetic technique used in that study. Was that prescribed at all?
As a cardiologist, I would definitely not prescribe or suggest what an anesthetist should do. I think that would be a very bad decision. And then, we think that obviously people should do what they think is appropriate. Obviously, the data in terms of whether or not the type of anesthetic is influencing outcomes with hip fractures is unknown. There's a trial that will finish soon that will obviously directly inform this. Obviously, one of the things that did happen that we had to get people to buy into is that if the patient, as an example, was on Plavix or they're on some antiplatelet that made them uncomfortable at regional, surgery was not going to be delayed if they were an accelerated care group. They had to go to general anesthetic. But it was left to the choice of the actual providers. In terms of the numbers, in terms of distribution, neural axial was 65% and general was 31%, and a mix of 3%.
Excellent. Thank you. And Paul, back to you. A couple of questions about two things, really. First of all, what do you mean exactly by immunonutrition? And secondarily, do you test routinely for vitamin or element deficiencies preoperatively, and do you routinely replace these?
Sure. So the immunonutrition is a good question. It's, for better or for worse, an unfortunate word I think that many of us realized we were stuck with years ago when these trials started. I think what we say when we mean immunonutrition really is a formula, an oral nutrition formula that contains arginine and often fish oil. And the reason it contains the amino acid and potentially that healthy fish oil, omega-3, is because we as humans have evolved over probably many, many thousands of years to have a system that after physical trauma allows for the turning down or turning off of the immune response so that we don't die of our own hyperinflammatory or immune state. And so whether you're malnourished or not, all of us sitting here today in the world, if we were to have a major operation, a substantial proportion of us will have our exhausted neutrophils begin to express arginase in our spleen and lymph nodes and other places and deplete our body's arginine supply, which is essential for lymphocyte division and certain T-cell receptor expressions. And it effectively immunosuppresses us about 2 to 3 days after a major trauma, like being hit by a car, being hit by a surgeon, being bitten by a tiger. They're all kind of the same, right? And so all of those things cause this response. And what we found is by giving arginine back, either before and after, or after surgery, we can reverse this immunosuppression that sets us up for a significant increased risk of infection. And the fish oil appears to turn down the arginase enzyme activity itself. You can actually directly measure that. And so Juan Ochoa and others have spent their careers with NIH funding studying this. And then now there's about 7,000 patients studied that show significant, our meta-analysis itself showed a reduction in infection of about 40 to 50%. In patients who receive these. And that's been true even in ERAS protocols where the use of an immunonutrition formula with arginine in it, so that's what we say that, versus a standard oral nutrition supplement, high protein supplement, still leads to less infections and less complications when an arginine formula is used versus just a regular protein containing formula. So that was done by the Spanish ERAS group. And so that's why I think people like myself who've spent their career trying to advocate for these formulas, and these are the specific formulas. The NIH has said the data for these are overwhelming. The biology is basic, understood, and described. we aren't really interested in funding this. Why aren't you implementing this? Why aren't your large societies making this fundamental? Why aren't governments, and the French government to some degree has done this. This is a mandatory part of their preoperative regimen in many areas in France. Why aren't this as a mandate that would reduce costs at a very low price? And so that's what we mean when we say immunonutrition. And then in terms of testing people, I think the one thing we've begun to do much more testing for at Duke is vitamin D. I think it's interesting. We have done a lot of vitamin D work in critical care. There was a positive trial showing reduction in mortality in JAMA that was then followed up by a multi-center trial by the ARDSNet that if you ask some of the leading statisticians in the U.S. and if you analyze the data correctly, it was actually positive, but the very simple statistical method the authors used to do it showed it wasn't positive, so it was very close to significance, but it missed. And so it was been viewed as a negative trial, but the data was very compelling. The Periop world has not done that trial yet, which is interesting. We do know that low vitamin D levels in various kinds of surgery lead to anywhere from a 2 to 4-fold increased risk of infection. Now, whether that's epiphenomenon of being otherwise malnourished or otherwise not optimally nourished and or healthy is hard to say without a trial. And so I think that really needs to be done. But vitamin D is very inexpensive to test for. It's the most common clinical laboratory test in the U.S. outside of the chemistries and CBCs. And 70%-ish of the U.S. population and most of the modern world's, or industrialized world's, a better way to put it, population is deficient. So we know that people at much higher risks for respiratory infections and other infections, we know that vitamin D is fundamentally essential to cathecydin and other macrophage functions and other immune functions, and it has significant relationships to cancer. There's a 100-study meta-analysis that shows D3 treatments can reduce all-cause mortality in populations when studied. And a lot of that we think is from infection and cancer. And now with COVID especially, it's true, I think. And so I think it's a huge opportunity for us in this specialty to do, but we do test for it and we do replete it. We replete it in surgery patients with 50,000 twice a week, which is a standard outpatient repletion dose the week before surgery. And then we give 50,000 a week, typically for 6 weeks after surgery. I always advocate to my patients if they would take 2,000 to 4,000 a day every day, they'd never have to think about this again. That's what I take. And that's 4,000 days what we're going to study in the COVID trials we're planning. So there are patients with GI disease that we do test other things in, like copper, B6, carnitine. Anyone on renal replacement therapy we're finding has dramatic deficiencies in some of these nutrients. But those are, of course, a much smaller population. So I think your IBD patient with significant GI losses, your fistula patients, they often have significant copper deficiencies, which can cause permanent neuromuscular weakness if left unchecked and untreated. We learned that from the bariatric world. And so I think copper is a big one if you've got persons with GI losses.
Okay, thank you. There's also some questions about self-nutritional assessment tools for patients, firstly. Would you recommend any? And the second one was, which I think I know the answer to, but with existing MRI or CT, can you ask a radiologist to give you a sarcopenia measure, which routinely, which I think the answer is probably not yet, but...
Yeah, it depends on the center.
On sarcopenia, I suppose the definitions on sarcopenia have changed. So they're not just about mass, it's also about function. So I think that's a really important thing, again, that we don't end up sticking with the old definitions, but that we are keeping up with the current literature. So I don't think a radiological assessment by itself is going to be sufficient to fit with current evidence.
No, but it's a useful start, probably.
A very useful start, but it is a start, and I think that's the important bit there. But Paul, it'd be kind of interesting to hear what your thoughts are.
No, and I think to touch the sarcopenia one first, I think it's important to differentiate Denny and what the role of measurements done by MRI, ultrasound, and CT scan show as a predictive index. I think they will be their own index that are separate from the traditional definition of sarcopenia, right, which does involve, in most cases, function and other things. I think they will be prognostic things like a vitamin D level or like an albumin or like a CRP. I think that our radiologists, interestingly, in the last few weeks, we have a very invested abdominal radiologist at Duke who's beginning to call John Whittle up in the SICU and call some of us in Periop clinic and say, this patient I just saw the CT on who's having colorectal surgery or just had their surgery and is in your SICU now has the worst muscle mass I've ever seen. You should consider them malnourished even though it appears their BMI is 50. And so I am starting to get phone calls from our radiologists because we've been so active in discussing this with them, where they will pick that out of a scan and call us and say, this person to me looks at severe risk for being very metabolically depleted. And so I think that's important because the global initiative on malnutrition guidelines that just came out last year from a whole group of experts around the world have now listed muscle mass content or total muscle mass as one of the defining features of malnutrition. This is the first time this has ever happened. And it can be done by BIA, which is bioimpedance analysis. It can be done by CT scan. It can be done by DEXA. It can be done by a lot of ultrasound or a range of things. And they've started to give cutoffs for what we should consider to be meaningful risk, where we've always depended on sort of patient self-described. Getting to your other question, I mean, most of the variables we use now are self-described patient responses to questions. And so they can be done. So asking a patient with an online survey, have you lost 10 pounds in the last 3 months or 6 months? Are you eating less than half of the normal meals you take? Those are excellent indicators of malnutrition risk. And so I think those are things that a patient could easily do on their own, answering on a computer or a piece of paper in the sort of waiting room. And then their albumin levels, obviously something that you might draw anyway. And then this other criteria now is this things we're getting from our routine CT scans, our MRIs, and potentially from our ultrasounds we carry in our pocket. And so I think that's the future of how we diagnose this and how we intervene on this. And then our ability then to follow it sequentially, I think, is also very promising.
Thanks very much again, Paul. I think we're just coming to the end of the session now. Quick one for Chloe. Psychological prehab rehab is important but often missed. When do you think we should get psychologists involved? And should it be involved both pre-op and post-op?
Excellent question. I guess my immediate reaction to that is it doesn't always need to be a psychologist. So those people that have looked at the guidance in prehab and we look at the triangle, in terms of clinical psych involvement, it's very few patients, and it's usually those that are presenting with pre-existing severe mental health illness. Psychological support and consideration should be there right at the beginning. And that's really about opening up discussions about how people are feeling, potentially using some screening tools, but doesn't necessarily require input from a psychologist. And it's important in prehab and obviously afterwards. Quite often we see that patients manage the immediate diagnosis of their disease. They battle through their treatment and they look to be doing really, really well. And then their treatment finishes, they're told, go home, you're well. And that's when they fall apart. And that's quite a common thing to see. And so sometimes that's missed because they seem to be very resilient, very robust people that have just flown and sailed through the treatment. But actually, it's when they go home, they really crumble. And that's a really important time to pick people up as well. But it's important. The clinical psych input's really important, particularly for those who are severely unwell, but it doesn't have to be that. And actually, specially trained nurses and CNSs have a huge role to play and do an excellent job in many places as well.
Excellent, thank you. And with that, I'd like to thank all the speakers for a really thought-provoking session and for answering so many questions, and Jugdeep for doing a sterling job at chairing us all. So thanks ever so much.
Top Med Talk.
Thanks for listening to Top Med Talk. We are excited to announce the World Congress of Perioperative Medicine happening in London this year. Check it out at ebpom.org. It will take you through to our carbon-free conference center where it has the EBPOM platform. You can find more information. Be sure to subscribe to Top Med Talk and EBPOM at ebpom.org.